Our guest speaker today is Stephen M. Crimando. Let's go ahead and get the presentation started. I have some information to share. Let's go over what you'll hear from today. So you're going to hear about logistics and introductions, which we're doing now. Overview of the CMS Emergency Preparedness Guidelines as they pertain to the local community. Coordinating with state and local authorities. Understanding ESFs, planning for special needs, access, and functioning needs. Locating key personnel. Developing communication plans, and then we'll have questions at the end. So today's guest speaker is Stephen M. Crimando. Stephen, how are you doing today?
I'm well, Sal. Thank you so much.
Thank you for joining us. So you are an internationally known consultant and educator specializing in the application of the behavioral sciences in homeland and private security, violence prevention, crisis management, and disaster response. You're also a certified trauma specialist, a certified police instructor, and you hold level 5 certifications in homeland security. You're frequently called upon by law enforcement agencies, the media, and the courts to provide insight on workplace, school, and community violence prevention. You're also called upon quite often to present at Everbridge webinars. So you are, we are appreciative of you coming and sharing your expertise today. And with that, why don't I give you presentation rights, and we will go ahead and get started.
Thanks so much, Sal, and thanks everyone for joining us today. Let me get my slides going very quickly. And please for everyone to remember that typically with all of our Everbridge webinars, these slides will be archived and the presentation will be available to you in the future. And very often people ask, because I know I try to put a lot of content into the program that you can use as a future reference, so please be sure to go back and try to find these slides at a future date and share them with others as well. So anyway, good afternoon and thanks everyone, and of course Sal, thanks so much for having me back as a speaker again. You know, it's not mentioned in my bio, but certainly for folks who know me or have worked with me, I spent about an equal part of my career working in state government, different parts of emergency management function, but also working in hospitals, primarily in the emergency departments of 5 or 6 different hospitals here in the New Jersey, New York metro area. So I have a perspective. I know it's not a unique perspective that really looks at both sides of the equation. When we talk about communicating and coordinating with the local community, I've been on both sides of the community. But I said it's also not a unique perspective because what I've learned working with hospitals very often is that a lot of folks who end up in hospital emergency management very often follow a similar pathway and have come from public sector, kind of a law enforcement, first responder, emergency management roles. But an equal number of folks who are in our audiences have come straight up, you know, through their own merit over the years through the ranks within a hospital system or within the hospital sector, and they're not quite as familiar about the government side or the public sector side. So one thing I'm fairly confident that most on the call are familiar with is the incident command system, and the hospitalized version of that we refer to sometimes as HICS, or hospital incident command systems. Now, all of that came into sharp focus, as you remember, in the post 9/11 environment. And the key concept, you know, of course, in the incident command system is this idea of interoperability. And interoperability at a very simple level is that our systems can very quickly, very effectively plug and play together. And if you think about something, and you know, not picking on an agency or a city per se, but this is, you know, obviously a key lesson learned on something like the morning of 9/11, is if police radios and fire radios are not communicating well with each other, we've got problems. And whether it's about telecommunications or it's just about planning methodologies, and even something as simple as language, and that's a key concept, of course, in incident command, is we're using a shared terminology, a shared lexicon of different ways of describing what we do. But one of the things that we see is that when we do start to bring critical partners to the table from both sides, you know, from both houses, community emergency responders and emergency planners, and our hospital-based and healthcare-based emergency planners, sometimes there's a mismatch in language, and sometimes there's a mismatch a little bit in expectations and assumptions we're making about capabilities. You know, obviously, where the rubber meets the road is during a crisis, and you know, certainly we've all been there, and understand that it's the wrong time to be making new friends. Certainly we want to have the relationships in place, and they come from planning, they come from exercising together, they come from slowly building trust, because most of us, again, are going to go into that crisis state very focused, sometimes very intense, sometimes it's a little bit emotional as well, and maybe even a little bit territorial. So it is not the optimal time for making those relationships during the crisis, but they're obviously very, very critical sorts of relationships. So when we start thinking about this then, as Sal said, our overview very quickly is talking about how do we start establishing and coordinating, but also speaking the language of the local authorities as we begin to flesh out the required emergency preparedness plan for CMS. We're going to, as part of that, look at the requirement as well for talking about special populations. And I'm going to bring this up a few times through the program, that we're going to be using the term vulnerable population, special population, and access and functional needs fairly interchangeably. And I know in different places across the country, that language, it varies a little bit and it's changing over time. But please know when I talk about a special population that I will be using, potentially any one of those three phrases. We're also going to talk about the importance of being able to locate key personnel on the fly, to give them instructions about, where to go, what to do, come in, stand down, what we need of them during an emergency situation when communications may be pretty stretched. And we're going to talk about really the need for flexibility in those communications in all phases, before, during, and after. It's a little bit of an overview. But from a kind of mindset standpoint, and I know this is easy for me to say, as someone who's not in your boots at the moment, but it is easier for me to say from someone who has been in those boots on both sides, in emergency management and also in hospitals, that this is actually a really interesting opportunity. And this is one of these funny kind of things. I know it's a little bit cliche, the expression of, it's not about the destination, it's about the journey. What you get out of almost, forcing yourself to structure your program to become compliant with the CMS rules, what you get, especially in this particular aspect of it about coordination with the external resources, is so valuable, and it is also so enduring. And what I mean by that is, even when it comes down to very small crises and the need to call 911, and we're not thinking about a major disaster in this situation, maybe disaster with a small d as opposed to a disaster with a capital D, big major catastrophic event. The relationships are there, the knowledge of each other, the speaking the same language, all those things are a byproduct of having gone through this process. And I invite you really to look at this process with that kind of optimistic view, as opposed to something forced upon us, or we're really concerned about the deadline and how are we going to do all this. Now, I also understand that we're speaking about just a narrow slice of the pie today. There's many other moving parts to the CMS rules. We're going to be focused mostly on that coordination piece, the collaboration piece, the communication section with our locals and understanding that. But in all aspects of the, really becoming compliant with the CMS rules, there is embedded in there, I believe, an opportunity that will outlive all the effort and all the sweat that you put into becoming compliant. So please, with that in mind, think about the information I share and how it really is going to help move you forward in general. Just really strengthen both internal and external relationships in your facilities and in your programs. So you are probably familiar by now of the, I believe, 17 different sorts of facilities and programs that the CMS rules apply to. I know we probably have folks on the call today from a number of different settings, inpatient, outpatient, and some things that are in between, perhaps. And I am going to, for simplicity, but also thinking that the majority of our participants today are from hospital or hospital-type settings, I'm going to by default use hospitals as our venue of choice today for most of the examples that I give and most of our discussion. Now, you'll also know that as you read through all the CMS rules, that there is this sense of a need for flexibility and a need to adapt what is being shared to your sort of setting. And I also understand, as you do, there's a lot of facilities that are hybrids, in which the same building we have inpatient care, and there's a wing of the building that's doing some sort of outpatient services as well. So this is, a pretty fluid sort of categorization, but the basic concept is this applies to pretty much every kind of setting that we can imagine that CMS has some sense of say or some sense of leverage in. But think about then how you adapt what I share with you to your unique setting. The overarching goal, I believe, from the CMS perspective is kind of closing the gaps, and that is really making sure that some of the places that were a little bit iffy before, there were recommendations and there were guidelines from different sources, but never something, as hard and fast as these rules, that these are really intended to make sure that there are not places, they're not the cracks that we risk important issues falling through. We want to make sure that everyone across the spectrum is applying a common, what's often in incident command systems referred to as a common operating picture or a common sort of mindset to this, because again, that fosters interoperability when we need to work together. So we want to look at this as a way of breaking down silos and a way of really fostering collaboration and communication. And as I said, while it's new to have rules, there weren't rules per se prior, but certainly instructions and guidance in the past. So the overarching goal, as I said, is address systemic kind of gaps, establish this continuity and consistency across all of our functions and across all of our different partners, and really encourage, I think is a kind word, is almost forcing us to go back and form those collaborative, coordinating sorts of relationships with all sorts of partners. And some of the partners I discussed with you today are going to be intuitive, and I think a few of them are going to be not probably as intuitive and maybe worth you thinking about a little further. So, under the old kind of approach rather than rules on the other approach, there really wasn't this hard and fast requirement for coordination with other health organizations or coordination with other local, state, federal, tribal, and regional emergency preparedness services. But we're here now, and this is, as I said, from my perspective, it's a really unique opportunity to kind of push us along a pathway in evolution. Now, the four core elements, as you know, of the CMS rules are this emergency planning section, policies and procedures, and we'll move on to the communications and other sections in a moment. But I wanted to mention that there's a lot of language in the CMS rules that talk about applying an all hazards approach. And whenever we're working together, it's important to remind people that all hazards should not be interpreted as a one-size-fits-all approach. So I want you to think about two key concepts as we kind of move, beyond this slide. And that is the idea that, the response, both individual and community response, but also organizational response to an emergency, to a crisis, is both phase-specific and hazard-specific. So let's go back to that for a second. By phase-specific, obviously, what our challenges are, how people are thinking and behaving, what our needs are going to be, very different in the first minutes as opposed to the first hours, the first days, the first weeks, and in some instances longer, down the timeline. So you need to think about all of this, including who will our critical partners be, because they may change across the timeline. And that's a very, very useful planning tool. And I'm going to mention that once or twice in terms of exercising as well. So make sure as you're thinking about an all hazards approach, that speaks more to the second comment I made, which was, the nature of disasters and emergencies is also to be hazard specific. And that's simply to say that the response to an active shooter event is critically different than fire, flood, earthquake, than disease outbreak, right? So we need to be flexible, and that's kind of, the push of all hazards is on one side to be very inclusive, but on the other side also to be very flexible. But do not interpret, all the language around all hazards to be this kind of universal template or a mindset that regardless of the crisis is, this is the way we do it. That may be true about the structure. We think about incident command structure. It may be true about how we fulfill these different requirements under the CMS rules. So in a structural way, the bones will be the same. But you'll also remember, whether we're talking about any model of interoperability, the need for flexibility and the need for scalability, right? So those are key concepts that come out of ICS or HICS, hospital incident command systems as well. So think about both of those ideas, about scalability and about flexibility, as you are considering anything that kind of speaks to us about all hazards. If you look at how the core elements are described, policies and procedures, they should also be based on a risk assessment, so we actually have a sense of what our vulnerabilities are. Are we planning for the right things? Are we planning for the kind of emergencies that are most probable, the kind of emergencies that are likely to be most severe? Really thinking that through and doing that in a methodical way as well. But you see in there, under policies and procedures, we start to talk about really tracking patients and staff as well. And I'm going to talk a little bit about this kind of from real-life experience, thinking about how we evacuated some facilities here in the Eastern Seaboard during Hurricane Sandy, about other events we've had where we've had to move patients out of facilities or do other kinds of movements, emergency movements, and a little bit of what we learned in those scenarios as well. But our focus today is primarily on the communications plan and the coordination with really with the locals. And the locals, I'm meaning something a little bit larger. I'm meaning, municipal and county and, state and federal partners, tribal partners, all of those different key players. And that downstream, it does lead us really to the importance of testing and exercising. And very important, one of the things we say often in exercise design is to remember the idea that during a crisis, we do not rise to the occasion. We fall to our training. So once you build this model, the testing of it becomes very, very important. I always promote you doing your testing kind of incrementally, starting with discussion-based exercises, working your way up to tabletop exercises before you jump into functions, really functional drills and such. So we're doing this and making sure we're getting it right along the way. The other thing about that, something to think about, is there's a real benefit to your workforce having, for you being some level of transparent in letting people see your exercises, and sometimes they see them obviously because they're involved, but to know about them, because it helps build confidence that, the organization knows what it's doing, is competent in it, has the relationships in place you need to respond to a crisis. But having said that, this is the whole point of making sure you do the discussion-based exercise, tabletops, and everything leading up to full functional drills. Because if something's wrong, we identify a gap, we find an issue, you want to do that in the lower level exercises rather than the more public sort of exercise that staff and others will see. Because if we don't do well with certain functions of that, it may actually erode confidence. So, as I said, we think about that idea that always remembering on tests and exercises, the purpose of the exercise is not to test people, it's to test the plan. So you want to make sure your plans are all in place, your plans are robust, they have those levels of redundance built in, and we've put them through that cycle of lower level testing before we really roll them out. So in section 1, let's jump right in and start talking about coordination with local, state, and other authorities. And Sal, here I'm going to ask you if you'd kind of launch the first poll question, and that question really has to do with, whether your current emergency management plans do in fact include working with the local community. So Sal, if you can go ahead and initiate that, and I'll just give everyone a second to kind of look at that and respond.
We got a good amount of votes coming in. You probably close it now.
So what's it look like? What's the general snapshot of that?
There you go. 92% said they do have a plan that includes working with the local community.
That's great. And I asked that early on, folks, because that's going to help us shape even the tenor of this conversation. So the vast majority have that in place. Now we're going to have another poll question in just a few moments that's going to take that down a little, drill that down a little bit deeper. But that means that some of these concepts are going to be more familiar to you, and certainly that many of you seem to already appreciate the importance of having that. So I want to introduce a concept if you're not familiar, and this kind of flows out of federal language, really from FEMA and coming out of the Stafford Act and ideas around federally declared or presidentially declared disasters, and that's the idea of CEMA. And that's the State Emergency Management Authority. Now we're going to start at the kind of top of the heap, and we'll bring this down to the county and the municipal level in just a moment or two. But a requirement is that every state, every territory, U.S. territory, all the tribes, in some way have identified a, one recognized state emergency management authority. That's like, the go-to. Who do we go to in that crisis to initiate, to start? Now, this is not saying that in every crisis, the State Emergency Management Authority is going to be activated or is going to be, involved. Obviously, you're familiar with the idea of all disasters beginning as local disasters, and, as we become overwhelmed in our capabilities, we reach out for support upstream to the county, to the state, to the feds, and so forth. But what this says is there's always someone there. If you're unsure in some way, who do I go to who can be kind of a consultant to me in identifying the key partners I would need, and who has relationships with some of those key partners, or an understanding of that. Really, if we start at the very top of the food chain, each state, as I said, has that one recognized, organization or agency that's deemed to be the authority. Now, in most states, that's freestanding. It's, if I think, for example, of my neighbors in Pennsylvania, we talk about an organization like PEMA, the Pennsylvania Emergency Management Agency. In a few states, and actually the only ones that really come to mind to me are New Jersey and Michigan, that the recognized or the State Emergency Management Authority is part of the state police, or as I said, in those two states where they're a branch or a subsection, or, kind of an office of emergency management within the state police. But in most instances, they're kind of freestanding. So these become kind of very critical gatekeepers because the State Emergency Management Authority has some responsibility for ensuring that downstream, down the food chain, there are county-level emergency management agencies and emergency managers who are going to be closer to where the rubber meets the road, who will know the local contacts, who know the physical terrain and know the challenges in there as well. And this is where, you and I start making those relationships, and it sounds like, 92% of us said, yeah, we've got some of that or all of those relationships we think in place already. But this section then, when you get to your overall CMS project, may be one of the lighter lifts for you then, if you do have those relationships. Now, within that, I will tell you that for the most part, if you dig down into the county level organizations, and sometimes depending if you're in a city, the municipal government as well, you'll have individuals who have a leadership role in special needs or access and functional needs kind of populations, and they're involved in developing registries both for facilities and programs and individuals in their local community. And all of these folks, they bring something different, they bring something special, but they bring different levels of kind of system knowledge and different levels of relationships that we can draw upon. But as I said, if you're not familiar, please know that this authority, this level of authority, it exists at every level, whether we're a state, a territory, or a tribe. You've got someone you can go to and say, listen, I know it's not you, but in my county, in my parish, in my jurisdiction, who are the key players I need to start with? And that's kind of where it starts. A general rule of thumb is you're probably better off erring on the side of over-inclusion rather than exclusivity, rather than saying, okay, the meeting, the group is going to get kind of a little bit out of control if we have too many voices, too many players. But when you start thinking about really who are our critical partners, you're probably better off starting with a list that's larger and trimming it back over time as you learn what's helpful and necessary. Because what happens is, and you know this, is if some organization or some individual feels left out of the process, there's often a price to pay for that, right? And the price can be, really being non-cooperative. It could be resistance. It could be sabotage. It really could be someone who sets you back because somehow they think they owned this part of the equation, and how could you have been so insensitive or ignorant to leave them out of the discussion? So think about that, and think about really a big tent approach to identifying your community partners, and maybe throwing back the ones who are not as viable as you go forward. But also from those organizations, you really want to get some key leadership people. And I get this. We all know how hard it is to get the time of leadership folks, of executives. I mean, to be on their calendar, to have them be able to free up an hour or so to come to a meeting or participate in a call, it is sometimes asking a lot of folks, but this is critical. And once we're past this, it's not going to be this labor intensive, but we need to focus on this now. You're looking for people from the organizations who, one, in your organization and then in your external relationships, who have a sense of the culture, locally. Where have there been issues? Where have there been kind of hard feelings over time? Where's there been a history of really great interoperability and cooperation and mutual aid that we could build on? So knowing who the players are, that's important, of course. Having a little bit of a sense of the history of that's important too, because that could be one of those, really one of those landmines, really one of those kind of tripwires that we set up the system, we try to identify the right agencies, we bring the right people to the table, and there's this unspoken dynamic that becomes a barrier. It just prevents us from really moving forward well. So you want someone or some folks who can really have a sense of the cultural history of the emergency management lay of the land, as it were, in your jurisdiction, but also trying to find those people who are responsible and have decision-making authority. The last thing you need to do, especially when we have a timeline we're working towards, is have that representative to the meeting come and say, hey, yeah, that's great, but I can't commit to this decision or that decision without running this up the flagpole and getting permission from my supervisors or superiors. We'll get back to you on that. So wherever possible, it's not just having the right organizations around the table. It's really important to have the right people from those organizations in terms of their level of authority there as well. So you're being a little bit selective. Now I want to tell you a little bit about this graphic. Back in fairly the immediate wake of 9/11, maybe a year or so later, I had worked with SAMHSA, and some of you will know SAMHSA. SAMHSA, the acronym is SAMHSA, the Substance Abuse Mental Health Services Administration. They're a part of Federal Health and Human Services, so obviously closely entwined here with our CMS project. They kicked off this all hazards project, and they sent a small training team of us to all of the FEMA regions around the country to host these meetings that were several day longs to actually kind of create all hazards plans and foster collaboration, all the good things that come through that sort of process. So this list was a recommended community partners that was kind of more specific for mental health organizations and substance abuse serving organizations and things like that. But it's a sample, right? And the point of this would be that very often you know, and 92% of you seem to say, we've got this, or some version of this already. You're going to know who your key partners are, or your counterparts in community emergency management. They will, back at County Office of Emergency Management or County Emergency Management Agency, however that's termed in your jurisdiction, they're going to have some version of this to know who all those key people are, key players. Now I want to move beyond that a little bit. Now, what you see, and remember that this checklist was kind of specific to mental health and substance abuse serving agencies. Some of these would apply to lots of your organizations as well. But one of the things that becomes important, and you notice this on the last slide, you may have seen a few boxes there on the punch list that were dedicated to things like Salvation Army and Red Cross and so forth, is the concept of VOADs. And if you're not as familiar, the acronym is Volunteer Organizations Active in Disaster, and these are community-based and faith-based organizations that often have a slice of the disaster response pie. And what I mean by that, very specifically, is they have some degree of responsibility or ownership for a very discrete function, like we do childcare, or we do feeding, or we do this, one thing. But it's also maybe that one thing that you really need in your plan. You really need a partner who's expert, who's experienced, who's geared up to do this. Your county and your regional emergency management authority, they know this, and very often they're working with VOAD. And here you see the secondary abbreviation or acronym, COAD, which indicates county organizations active in disaster. And this just brings it a little closer to home for us. But as you're thinking, about inclusion, really consider who those VOADs are and just, how important their services would be in different sorts of disaster scenarios. Now, obviously, they're not going to be part of every sort of disaster scenario, but what they do is very unique, and they tend to be very, very good at it, and you want to make sure you're getting them involved. They also tend to be a good bridge or pathway to other relationships as well. Now, in these relationships, and many of you, of the 92% who said, I get it, we have in place different kinds of relationships, is, really about speaking the language. So, Sal, if you could, I want to go to our second poll question. And the question very simply is, before we go too much further, is, are you aware, are you familiar with what we refer to as ESFs, or emergency service functions? Is that a term, a language, a concept that you're familiar with and you're working with? So, Sal, I'll let you, handle the poll aspect of that.
Sure, launch. So filling in quickly. We give it another couple of seconds, or about halfway. Half of you have voted so far. Don't be shy. We're not going to track you. And starting to stabilize.
And I would say in the envelope, please, but that's tricky these days, right? So.
Yeah, no, that guarantees nothing. So there you go. There you go.
And what are the numbers? Tell me what it looks like, Sal.
Sure. If you take a look at your screen, so 28% have not heard of ESFs, 42% have but only understand the basics, and then 30% feel that they have and are familiar with them.
Okay, and all of that is good news to me. All that's good news because the folks who aren't familiar, you're gonna, this is a good takeaway. People who can require a little more knowledge and maybe acquaintance to it will benefit, and this is good reinforcement then for folks who feel themselves very knowledgeable and familiar with ESFs. ESFs are the language spoken by the emergency management community. Almost everything they look at through the lens of which emergency service function does this specific need line up with. Now, the good news is when you start to really drill down into the emergency service functions. You'll understand that a lot of them, maybe most of them, actually align themselves very, very closely with really the requirements of the CMS, at least this section of the CMS rules, in terms of building a bridge between the emergency management personnel and organization, both in the healthcare organization and in the community organization as well. These are the ESFs. Please notice what I put up in that little call-out box to the right there. Don't confuse these 15 emergency support functions as with our 16 critical infrastructures in the U.S. as defined by Homeland Security. This is a different thing. But this is how emergency managers and emergency management organizations conceptualize really preparing for what the needs will be in an all hazards way, all different sorts of emergencies. Now you can see I highlighted in a different color here ESF 2, 6, and 8, and that's going to be the focus of our discussion pretty quickly. ESFs in general, they flow out of what many of you know is the National Response Framework. That was kind of the second iteration of the National Incident Management System, and it's really creates the model that's national. As I said, when I mean national, I mean also out to our U.S. territories, tribal organizations and such. Really, all these communities have to march by the same sheet of music. It helps you then at the hospital and healthcare level to understand the basics of the ESFs, or at least be able to speak this language. So when you're talking about, how would we evacuate patients and where would we take them to if there's a medical needs shelter? Well, that fits in a particular ESF. If we're talking about folks with different access and functional needs, how do we plan for them? Your community emergency managers see that through the lens of ESFs. Now, in general, please notice just the last two bullets here that I've highlighted. The ESF in general, or the ESF, let me go back one step there. I'll go stick where we were. The ESF coordinators, and really that is a discrete role within the different state, federal, county, local emergency management agencies. The coordinator who oversees really preparing for and ensuring that the ESFs are straightened out also serves very often as a representative on different task forces and ad hoc groups that are planning. That means it's someone who could be a technical expert to you. So you've got someone, if you could liberate them to attend your meetings or get on phone calls, who knows this stuff inside out, who could tell you, you know what, in the county, when we talk about ESF 6 or 8 about mass care or about sheltering and things of this nature, this is what we have in place. And these are all the key partners that we've aligned with. These are all the VOADs that we've identified. So the ESF coordinator is going to be a really critical person for you. And one of their mandates, and I mean this is right out of FEMA's language, is coordination with with other agencies, with private sector, with nonprofits, with NGOs and such, really to be that conduit for you. So use that. They are your subject matter expert on ESFs, which become the bridge, right? So what we're looking to do is translate the language of CMS to the language of ESF, and back and forth, have an interpreter who can take ESF concepts and translate them into our needs, really with our key points in our CMS rules. Now, when there's a disaster, not every sort of incident disaster requires the activation of the ESFs. Some are simple or very limited in scope and do not require kind of activating this. But the other thing to think about is ESFs can also be selectively activated in different sorts of disasters, and some of them will be major disaster declarations, and some will be presidentially declared disasters, other kinds of homeland security issues as well. And they also can be done in a modular way, which means you do not have to activate all 15 of those, right? It could be that in this instance, we just need to activate, for example, here on this slide, ESF 2, ESF 6, ESF 8. And these in specific are the ones I highlighted on that longer list. ESF number 2 is about communications. That's part about, our discussion today, one of your real specific CMS rules. Number 6 is about mass care. Number 8 is about public health and about medical services, medical care. So those are all things we need to know about, and we need to know what the community is doing and how they're thinking and what their resources are about this as well. Now, the purpose of 6, ESF 6, is mass care. It's things like sheltering. And when we think about those organizations where we would potentially have to evacuate or move folks to different kinds of specialized settings, this is where your ESF coordinator has, 1, applied a lot of critical thinking, but 2, identified the right resources. Where are the places in the county or your jurisdiction that are suited for that type of sheltering or that type of mass care? You'll also notice that things like human services are baked into ESF 6 as well. And we're going to touch on that a little bit. But from a ConOps or concept of operations sort of standpoint, understand, as I said, that this touches, the ESF 6 touches and coordinates all levels of government and the private sector, and ties together response activities and recovery activities concurrently. So they're not kind of segmented. We're really thinking about the whole scope of the disaster, and we want to initiate care for victims very, very quickly and have the resources in place, obviously. So when we think about the emergency assistance section of ESF 6, it's things like evacuation and more specifically specialized evacuation. If your hospital has an inpatient psychiatric unit, especially a locked, committed unit, it's going to require a very specialized kind of evacuation. If you have people in very intensive care settings, if there's some sort of scenario that forces an external evacuation, where are you going with those folks? How are we doing that? But it also here, and this is interesting because both ESF 6 and ESF 8 do touch on special needs populations. And you remember before, I'll be using special needs, vulnerable populations, and access and functional needs interchangeably. Coordinations of donations, coordinations of volunteers, but very specialized medical shelters and non-conventional shelters. For those organizations that are involved in rehab right now, right, we're all keenly aware that we're in a kind of a national opioid abuse or addiction sort of epidemic. And if we move people out of a treatment facility or a hospital that has a detox, what does that look like in an emergency? Where do we go for sheltering? How are those needs covered? All of those very specialized questions are kind of dealt with in ESF 6. So important to know that. Now 8 changes direction just a little bit. 8's talking about public health and medical services. And so we have much more of an involvement of our public health authorities, the health department, public health emergency personnel, and we give examples here of something like pan flu or a bioterror attack, but it also occurs or applies rather to natural disasters of all sorts. But this is really where we're not thinking about the sheltering of people, we're thinking about the medical care and the public health needs. Now I have to tell you, really interesting experience for me was after the first 2 weeks of being on the pilot Ground Zero or working our family support, family assistance centers back and forth to the pilot Ground Zero, I was redeployed down to run psych operations at the Anthrax Screening Center in and around Trenton and Princeton, New Jersey in the fall of 2001. So you got to see in that transition from 2 different, very different sorts of public health emergencies, different sorts of emergency management crises, the need for the flexibility and scalability, but also the specialization that the kind of ESF concept brings to bear. Here again, I did highlight, you start to see attention to our special needs populations. You have some other things that are covered in ESF 6 that may be important to you from a hospital planning standpoint, and there are things like medical equipment. And, here are our photograph of the oxygen tanks and so forth, kind of captures that well, but also security, and all these other ancillary sort of medical issues. So this is a place where you want to be very familiar with the ESF coordinator, and everything they have to bring to bear. When we start to talk about special needs, the basic idea is that in disasters and emergencies, individuals with special needs have essentially all the same needs as everybody else, and then some, right? So whether it's mobility challenges, it's communications challenges, intellectual or developmental disabilities, other kinds of disabilities, we really need to start thinking about how does that affect them. Things like evacuation, how does it affect things like, transportation of patients, things of this nature. So we do have to have a focus on it, and as I said, it's a key part, of course, of our CMS rules, and it's a key part of what's discussed in both ESF 6 and 8, mass sheltering, evacuation, but it also talks about pre-hospital care. So if your hospital does run ALS or paramedic units, this is places where you need to start, making sure there's a high degree of coordination around that as well. Now, one of the things you may be familiar with, and if you're not, I just want to introduce the concept really quickly, is special needs registries. This is a way pre-event that emergency management agencies in the community, some at the municipal level and some at the county level, have thought about how do we identify people in our jurisdiction who will have those special needs during a disaster. Now, this is the community I'm speaking of. So how do we know, who in a neighborhood has a special need around maybe mobility that will affect us if we send an ambulance out in a response, something like that. But the same concept applies back towards the hospital. We talk about organizations that need this then. And here I have a great example kind of close to home for me down along the Jersey Shore. Monmouth County had been very proactive in developing a special needs registry. And in the photographs, what you see very quickly is on the door to the left, on the door of the individual's home, this is a sticker that kind of says that to first responders, whether it's law enforcement coming in or EMS coming in. We have an individual in this home who's part of the registry. That means I'm going in with a sensitivity, but it also means I can go online. I could get information before I even have contact with the patient that tells me about those needs, the best way to approach them, really anything I should understand. And the photograph to the right is that very same sort of decal on the back of someone's vehicle on their car window. So as we start thinking about special needs and the CMS requirements around that, it is very likely that your emergency management officials and representatives in the community have this piece down. Now, that's going to vary, across the country and, across all our tribes and territories. But the concept is not necessarily new. Where individuals and communities are with that in their evolution, that is a little bit different as well. So we've got our last two sections here, and they're going to go pretty quickly. And then we're going to get to some material from Sal and a few questions and questions and answers, I hope, which is locating key personnel. And this is part of our CMS requirements as well. And right out of the language, from CMS, is providers must develop policies and procedures to track and location of staff and patients during and after. And, the need for that is self-explanatory. Just in terms of accountability, knowing where your people are, the ability to reach them and just know that they're well, that they haven't been injured, and then also to think about how we move people, moving staff and moving patients. Now, this is interesting. The requirements are that we do have to track patients within our facility and what we're doing. But once a patient is transferred out to a different facilities, kind of the tracking requirement, it gets passed along. It kind of follows the patient to some degree. So we don't have a requirement for logging and tracking in the same way. But it is critical, of course, to know where your key personnel are, where they are, that they're okay, and how you can move them about. Now, it's interesting because there's really, the methods exist today and the requirements exist today for automating this. So you do have this at your fingertips. And the core concept, obviously, is redundancy, that messages go out to staff, messages go out to our key partners in multiple formats, such as text and voice and others as well. So we don't rely on a kind of a single point of failure with this kind of critical communications. So recall, redeployment, sending people to alternate sites, we need to know where our folks are and how to reach them. And obviously the how to reach them speaks to our last pillar here for today, and that's simply our communications plan. The kind of CMS posture really is broad in who we communicate with and how we communicate with, but we never lose sight of our HIPAA sorts of obligations in thinking about the nature of sensitive material we're sharing. So that's always a tricky balance of sharing need-to-know information and thinking about what channels we move that around in. But the CMS rule is that providers must and suppliers must document efforts to cooperate and collaborate with emergency officials and log our communications. So the requirement here, the rule starts to talk to us about a communications platform that documents both directions, messages sent and received to our key partners. And that's important for just understanding the flow of the events. It's important for after-action reports. It's important for defensibility should you ever have to account for and explain the logic or where we had a point of failure in our communications. So this becomes a very critical part of it as well. You know, obviously, we need to be able to detail how we're communicating both on-duty and off-duty staff, how we're communicating those designated emergency management partners, how we're communicating using various means. And if you don't see that in the third, fourth bullet down there, the third, I believe, very important, and I've seen this often, and many of you have as well, is the reliance and just the importance of ham operators or amateur radio operators as a redundant form of communication or a specialized communication channel for us in different emergencies. So I'm going to start moving to closing this up. And as I said, going into this with the knowledge that 92% of you had what you deem to be good working relationships, that a fair number of you had a good awareness of ESFs in general. I'm hoping that when we get to this section and you are tackling this section of your project, that maybe both your existing knowledge and skills and a little bit of what we share today makes this part of the project a little more manageable for you. So remember, again, closing, just going through this process, it's time well spent, building the relationships, speaking the language, knowing the cultures, and again, eliminating any sense of territorialism or misunderstandings pre-event. So it's all good stuff. You know, what we're being kind of pushed to do, it's necessary and it's tremendously helpful. I like to close out this kind of presentation with the quote from JFK back, one of his State of the Union addresses: "The time to repair the roof is when the sun is shining." Obviously, everything we do in emergency management is based on this idea that it has to be pre-event. So keep up the good work, everyone. I wish you the very best of luck with your CMS projects, but I think a lot of you sound like you're in a pretty good place around this one component, and you have a way to reach out to Sal, and you have a way to reach out to me should you need any further assistance from us. So Sal, I'll leave it to you to take over and take it back.
As I mentioned earlier, we have a couple of questions that have already came in, but Q&A will be starting shortly, so please submit those questions. I did really quickly want to cover just who Everbridge is and what we do, and in reference to kind of why we had this webinar. Many of you on the line are familiar with Everbridge, but some of you are not. Everbridge is a critical communication platform. We really provide healthcare facilities and hospitals such as yourselves the ability to communicate in 3 different areas, so around safety and security, around IT operations and business operations, and emergency departments / clinical communication. So here at Everbridge, we like to say that good communication is good medicine, and we like to sort of live that in terms of, you know, if you are keeping your staff and patients safe from natural and man-made disasters, that's a form of medicine. If you are keeping your systems running so that you can provide health care and actually see patients, that's a form of medicine. If you are making your clinical communications more efficient and getting the right doctor to the right patient faster, or the right information to the right provider faster, that's a form of medicine as well. So kind of 3 main areas that we focus on. In terms of the CMS criteria, you know, part of the reason why we had this webinar is, as many of you know, there's new CMS criteria that people are going to have to be compliant with our facilities are going to have to be compliant with by November of 2017. Our presenter today spoke to a couple of those. We've done a lot of homework on this, trying to figure them out for our clients and our prospects and our friends and partners. We've come up with a couple of key areas where we think our software can play a key role. So, for example, being able to communicate with your entire staff is something that the new CMS criteria says needs to be done. The scalability of Everbridge allows you to execute on something like that. You need to be able to run drills and prove that you ran drills, and that's part of what with what Steve said about sort of audit trails and things like that. So we do allow for that. And another part of being able to run drills is templates. So templates play a huge role. We allow you to set up your different templates according to your different crisis management scenarios. That's also an area of the ability to communicate to the community at large in terms of languages. So that's another criteria, is you need to be able to communicate if there's a large contingent of the population that speaks a specific language, you need to be able to communicate with them in that language. That's where communities can come, that's where templates can come into play. And even our IT alerting, our IT operations module, part of what CMS says that you need to be able to do is be able to communicate around the energy status, the power status of your hospital, and our IT alerting system has integrated with other systems so that you can sort of leverage the Internet of Things to monitor power sources. I just bring up Hurricane Matthew is a good example for those of you kind of wondering, can Everbridge really handle this kind of thing? Not over 900 entities used Everbridge during Hurricane Matthew, including the entire state of Florida, which is a client of ours. During that incident, 3 hospitals were evacuated. Three Everbridge hospitals were evacuated because of Hurricane Matthew. So if you can think of the communication challenges around evacuating a hospital, getting the staff on board with that, all while remaining sort of HIPAA compliant, I think that gives you an idea of how Everbridge sort of can power your communications for your crisis management scenarios. So with that, I do want to talk about questions that we do have that we have had come in. So I'll just start with the first one. This isn't a question, but just something that one of our speakers brought up. So Steve, when you were talking about ESFs, one of our attendees, Jim, said the FEMA course I-120 and L-0146 are classroom trainings that can help you understand ESFs. I don't know if you want to respond to that or if that's something new to you, but I just thought I'd share that.
No, absolutely. And you know, if you're not familiar, the online training programs through FEMA's EMI, Emergency Management Institute, they cover much of this and more. So you actually can not only take specific courses about the ESFs in general, but there are very robust programs on each of the ESFs, and that's a great way kind of to self-study and learn more about these. The other way, as I said, beyond the self-study and doing the online courses from FEMA, is maybe having someone come from your local emergency management agency and do a little bit of a presentation to your group, because not only you're getting the knowledge, but you're helping to kind of build that relationship as well. But certainly, today should not be the beginning and end of your learning about ESFs, whether it's through FEMA or through your partner.
Perfect, perfect. I have a question that came in here sort of early on in the webinar, but I'll go ahead and ask. I don't know if it's particularly about some of the topics, but it is about sort of communication. So please recommend or comment on ways to get first responding agencies to share or authorized first receivers to have access to the radio channels used by first responders. I have P25 radios on their radio system, but only authorized for EOC channels. I currently glean my info from a commercial phone app to get an early start on my preparedness for real-life events.
Yeah, this is one of those things, again, that are kind of systems issues, and this happens in a number of places, and we hate to have to think that you have to be like listening to a scanner app on your phone to get a heads up. I have to tell you that, we all understand the importance of that. Where that's coming from in your jurisdiction, why that's the territorial aspect of that, if you have not raised that already, which I imagine you have, really needs to go back to kind of, I would think, even back to whoever regulates EMS in your state, and that may be your Department of Health, it may be some other department, and, you know, almost make a business case about that, about either real scenarios or hypothetical scenarios about where that's going to trip you up, where that's going to compromise patient care, where that's going to be, you know, be a bigger issue. That's a little bit, it's a little bit artificial. You know, I hate to say it, but when we go back sometimes and ask folks why it's done that way, the answer is because it's always been done that way. And in the current environment, to say, hey, you know what, anybody can get this. You can download this app for 99 cents and anybody can be listening in on this channel. Depriving us of access to the channel, it's, you know, it doesn't work for anybody. So because the technologies can continue to evolve, because the kind of landscape evolves around us, even if you've broached this topic before with leadership, I think there's always going to be new opportunities to go back and kind of, you know, really push this so there's greater kind of hospital, you know, first responder, first receiver access. From my perspective as a former EMT and also an emergency department worker, I kind of get it and I can understand your frustration. But I guess if nothing else, I'd say keep up the fight and keep the discussion alive, especially since apps are allowing anyone in the community to listen to this at this point.
This is really this is one of the first times where kind of the emergency response plan can really get the eyes and attention of leadership, kind of as you mentioned, just because CMS, you know, Medicare patients are CMS compliant, you must be CMS compliant. So there's really a bottom line issue here that didn't exist before. Can you talk about maybe some of both the challenges and the opportunities that you may have by having, say, like the C-level's ear in a way that you didn't have before now that these new changes are coming out?
Well, I guess the challenge, kind of the balance between challenge and complexity is finding that sweet spot while you have these folks' attention. And you have them, as you said, Sal, because it's a bottom line issue. You know, we don't do this, we're not going to be able to participate and reap those revenues. Is finding that place where we're not overwhelming them with the kind of minutia and all the technical aspects that we in the fields, our various fields, speak with. I think you need to speak to them when you can get their attention about the larger concepts, about the benefits of this. And the benefits obviously are much, much more important than just compliance with CMS. They also have to do with things like recruitment and retention, right? They have to do with employee morale, and they have to do with the reputation of your organization and your market share. So I think one of the ways that you can leverage and maximize your opportunity in front of the C-suite is to actually look at this as a kind of a business case. And think about this beyond just like, you know, clearing the path for Medicaid, Medicare. How do we, by being CMS compliant, actually improve brand, reputation, defensibility of our actions, and reduce litigation? How do we become better known in the community? And the bottom line is this, guys, and I think I'm preaching to the choir in this last statement. When it goes wrong in your community, the goodwill, you know, that the people walk away with, what they remember that you've done for them in the crisis, honestly, they will never forget. So the loyalty in the marketplace, the loyalty to your hospital or healthcare organization that is built during a crisis is enduring. And the missed opportunity of not getting it right and not performing well during a crisis is something that the C-suite, they may never recover from. That group may not outlive how long it takes for your organization's reputation to change. So, guys, remember this. A crisis, right, it's a moment of truth. And, you know, I guess I'll sum it up, Sal. I think it's a statement usually attributed to Maya Angelou. And she said, you know, after it's all said and done, people are not going to remember what you said to them, what you did. They're going to remember how you made them feel. And if people in the organization feel that you knew what you were doing and you were excellent at this, that builds loyalty in-house for recruitment and retention. And in the community, if they feel that we were competent and we were caring and we knew what we were doing, that builds a customer base and a loyalty that money can't buy. So if you think about that fact, crisis as an opportunity, crisis, really as a moment of truth, that should ring in the ears of your C-suite personnel.
Awesome. The feedback we've gotten is good so far. So again, thank you for everyone attended. If you're looking for information from Everbridge, how we can help you with those CMS criteria and how our software can sort of assist in some of that, please do fill out a contact us from everbridge.com. We'd be happy to speak to you, and good luck to everybody. So thank you, everyone.